Restorative Dentistry Department, about 2 hours, 8 to 10 a.m. First, I would like to have a brief introduction of Restorative Department and its faculty members. First, I would like to know and inform you that at Restorative Dentistry Department, you will learn how to conservatively restore the lost tooth structure, such as excessive tooth wear, as you see here, using different conservative, restorative, and prosthodontics approach to rehabilitate the lost form, function, and very important issue, aesthetic. You'll also learn how to give your patients a healthy, gorgeous smile using conservative and even ultra-conservative approaches using porcelain veneers to tooth bleaching or other approaches. We have 11 faculty members, including the head of Restorative Dentistry Department and other colleagues, and other colleagues as you see here. And today we have scheduled 2 presentations for you. And the topics about the restorations of non-vital tooth with fiber reinforced composite wallpapering technique. The research deputy of the Restorative Dentistry Department, Dr. Sara Valizadeh, will present the details of this topic to you. After Dr. Valizade's presentations, you would have a break and then demonstration video illustrate to you how you can do it. 3 articles have been uploaded in Navid system on Friday 12th, and I hope you have read it. At the end, if you have any question, it will be answered, and if any time remains, some cases will be presented and it will be talked about the restorative treatment planning of this endodontic to treat the teeth. Okay, Dr. Valizadeh, stage is yours. Dr. Valizadeh, would you please start your presentation? Thank you.
Thanks, Dr. Mutawasilian. Hi, everybody. Hi, everybody. Welcome to this session of Winter School. Nice to virtually meet you all. As Fariba, my friend and colleague said, I am Dr. Sara Valizadeh, and I'm an assistant professor in Restorative Dentistry Department of Tehran University of Medical Sciences. Firstly, I want to thank TUMS for providing great opportunity, and I'm very happy to be here with you. Would you please show my slides? Yes. Okay. In this lecture, I want to tell something about restoration of non-vital tooth with fiber reinforced composite wallpapering technique. Actually, this technique has been introduced by Professor Deliperi, and if you search the literature, you can find many articles of him. And also, we have done this treatment in our departments. And we have a research article, case reports article in collaboration with him too. And I think that it is available on your Navid system too. Okay, let's have a look at these teeth. All of us as a dentist that face with these teeth in our mouths of our patients. And when I look at these teeth, there are common criteria between them. And this is the losing lots of the structure of these teeth. And because of this, the biomechanical principles compromised here. We know that endodontically treated teeth are weakened and susceptible to fracture more than teeth with healthy pulp. And as we know, there are many reasons for that. For example, decreasing in water content or loss of dentine, reduced dentinal elasticity, decay process, and also tooth preparation for adequate endodontic treatment. After endodontic therapy, selecting appropriate reconstruction for non-vital tooth should be based on these factors: remaining hard tooth tissue structure, number and thickness of residual cavity walls, position of tooth in the arch, and load that implied on the tooth. When we face the RCT tooth, we have many options for treating them as direct and indirect restorations. Direct restorations, as you can see in this slide, are like amalgam buildup, composite buildup, and also we have PFM crown and balsamic crown, and in recent years also endocrown for restoration of ETTs. Let's have a quick look at these restorations one by one. Amalgam has been used in restoration of a structurally compromised posterior teeth for many years, but it has some drawbacks, like it is anesthetic restorations, and many patients doesn't like the metallic appearance of these restorations. And also it does not bond to tooth structure, and it is a brittle material. Metal-based restoration and residual tooth structure behave as two different entities, and they are not, and also they are not bonded to residual tooth structure. Moreover, need for mechanical retention or resistance forms, such as boxes, grooves, slots, pins, create regions of great stress concentration that dramatically weaken residual tooth structure and increase potential for crack formation. As we know, for many years, PFM, post-core crown, was considered as a gold standard for treating these teeth. And previously, these teeth were automatically treated with post-core and crown. But they have some complications too. For example, when we are trying to prepare the post space, maybe root perforation happens, or we should sacrifice lots of the structure for receiving crown, and also they are expensive treatments, and maybe some patients couldn't afford the cost of it. And also there are some situations that it is impossible to use intraradicular post. Consider abnormal root canal anatomy with super curvy roots, and also when we have short roots and we cannot use the whole length of the root canal, or we have a broken file or MTA inside the canal. And also when we have insufficient crown height, and this is very common in second upper molar, and because we have no retentive crown in this area, the crown, instead of being in your patient's mouth, it's always in your hands, in his hands. So it is not possible to have the best crown for these patients. And the other restoration could be considered is composite restoration. We know that we use composite restorations in small to medium-sized intracoronal lesions, and maybe there is some concern about using it in large restoration, and this assumption is based on poor wear characteristics and also marginal behavior of early RBC. However, recent literature review reported increased predictability of direct resin-based composite restoration, and has encouraged clinicians to progressively abandon amalgam restoration and shift it to composite restoration. And this is the consequence of different phenomena like continuous development of adhesive system, improvement of resin-based composite physical and mechanical properties, and also patients has important role here. Patients' demand for aesthetic restoration and patients' increasing desire to save remaining sound tooth structure, and also inability to afford indirect restoration cost. Resin-based composite restoration have been used to restore posterior teeth about 40 years, and we all know about the drawbacks of composite resin as well, and concerns still exist with regard to composite wear, less than ideal bonding to dentine, stress from polymerization shrinkage, and also technique sensitivity. But composite improvements in physical and mechanical properties and also aesthetic appearance can result in progressive use of composite, more tooth tissue preservation, and also more affordable treatment for patients. So in these years, main goal of new build-up protocol is preservation and reinforcement of remaining sound tooth structure. As you know, the most important drawback of composites is polymerization shrinkage that produces stresses in tooth restoration interface. And we use several methods for compensating these stresses, like incremental technique for cavity composite insertion, and also soft start or ramp curing mode. The other drawback of large composite restoration is about toughness. Composite restoration is a rigid material, but it lacks toughness. And you know the definition of toughness, it is the material resistance to rapid propagation of crack. And it is an inherent material property and predicting structural performance. Okay, so what should we do to overcome to this drawback? The answer is using fiber reinforced composite restoration and use fibers in combination inside the composite restoration. That increase durability of these restorations, enhance composite stiffness, and provide better force distribution along the fibers that inserted into the composite restoration. So FRC development has increased use of composite materials in an extensive preparation these days. Mechanical properties of FRC structures have been found to be superior to that of non-reinforced composite. FRC structure consists of light cure monomer holding fibers together in composite structure, whereas the fibers is reinforcing part and providing stability and stiffness of this restoration. There are commonly two types of fibers that used in dentistry, and they are glass fibers and polyethylene fibers. Glass fibers has high tensile strength, high modulus of elasticity, excellent mechanical properties, good bonding strength, and also they have a transparent appearance. So these are suitable for area with high aesthetic demands. And polyethylene fibers are most durable reinforcing fibers. They have low modulus of elasticity, low density, good impact resistance, and they are white in color. So we can use them in aesthetic dental applications. And with surface treatment of this, we can get good bonding properties. Effectiveness of fiber reinforced technology is dependent on many variables: type of resin that we used, quantity of fibers, fiber type, length, and orientation, and also adhesion to the polymer matrix. As you can see, there are lots of fiber brands available in the market, and For example, we can name rebound, everlastic, construct, connect, and you can see that they have different composition, polyethylene fibers or glass fibers. Recently improved Mwp Fiber System. I know the name is very long, but it is abbreviation for ultra high molecular weight polyethylene fibers have been introduced onto the market, that they have greater strength properties than conventional fiber. And this is because of structural that it has. It has unidirectional fibers with braided filaments inserted between them, as you can see in this slide. The woven fibers have several advantages, like create great multitude of load paths and also redistribute occlusal forces throughout greater region of dental composites. And these polyethylene fibers are plasma treated fibers, increase composite toughness, and increasing durability and damage tolerance of this restoration. We all know that during tooth lifetime, a wide range of overload events may happen. For example, high extrinsic loads like bruxism and trauma may happen, or intrinsic chewing stroke in a small area due to the hard foreign body such as a stone or seeds may happen. But in healthy tooth, there are some structure that help tooth to be safe and prevent fracture. And one of them is dentino-enamel junction, DEJ, that successfully unites two very dissimilar dental materials together. One is hard and wear resistance enamel cover layer, and the other one is softer and less mineralized dentin core. DEJ enable harmonious transfer of stress between dentin and enamel and allows them to function together as a unit, and also provide crack arresting barrier to crack formed in enamel. And we can see that despite formation of multiple crack within enamel during lifetime of exposure of masticatory forces, it is unlikely to fail with healthy tooth. There is little consensus on mechanism of crack arrest and DEJ, but all of the research agrees that DEJ has an important role in this mechanism, and it is a very durable, damage tolerant, very strong and well-bonded interface. Structurally compromised teeth are exhibiting substantial loss of tooth structure due to the previous caries, pre-existing restorations, and endodontic procedures. So the more structurally compromised the teeth, the lower is proportion of DEJ region in the tooth, and the higher is potential of catastrophic failure of residual tooth structure. And when we combine the use of fibers along the cavity walls in the wallpapering technique, we use it in order to replicate the loss of DEJ. So higher modulus of elasticity and lower flexural modulus of polyethylene fibers in this technique have modifying effect on increasing interfacial stress development along cavity walls. And research reported a fail-safe mechanism in the wallpapering technique. It means that fracture generally occur above the cemento-enamel junction in FRC restorations, especially in wallpapering technique. And it shows that the remaining tooth structure is restorable and catastrophic failures are avoided. The strategic fiber insertion against the cavity wall may contribute to avoid failure, and it does it with stress distribution and energy absorbing mechanism. So FRC restorations are one-visit treatment, can preserve sound tooth structure and also have reduced costs. So these factors make FRC restorations acceptable treatment for endodontically treated reconstruction, and it may delay or preventing complex indirect restoration. But the important thing is case selection. We should have correct case selection and also correct use of material in order to achieve good results. Okay, now I want to present two cases with you, but I'm not going to explain about every detail of that because I know that after my lecture, Dr. Motawasselian had demonstration in this technique, and she will explain detail and step-by-step these procedures. But let's have a quick look at these cases. These are two patients that come in our department. One of them is a 20-year-old male patient, and the other one is a 35-year-old female that they have RCT, root canal therapy, on their upper molars. And we explained to them that the best options for the restoration of these teeth is ceramic endocrown, but according to some financial issue, they didn't accept it. So we went for doing fiber reinforced composite restoration wallpapering technique. First, remove the temporary restoration, and then cavity was prepped, very conservative, and being sure to remove all decayed dental tissue and preserving tooth structure as much as possible. And then residual sharp angles and supported enamels were smooth, and no bevel were placed on occlusal and gingival margins. And Antiphylomyometrics placed and etching bonding was done. And the first part that we reconstruct was a missing peripheral tooth structure. And then after that, we removed the Antiphylomyometrics and select the correct length of fibers and place them against the cavity wall in facial and lingual, and somehow extension happens, and it passes through line angles, and also and also it continues, it extends onto the about 1/3 of mesial and distal proximal surfaces. And then after adaptation, we continue with composite restoration, and composite buildup was done, and finishing and polishing and occlusal adjustment also was done. And you can see the final result of these two FRC restorations. In the wallpapering technique, precise evaluation of patients' criteria is mandatory. And if the patients have parafunctional habits and heavy occlusion, maybe we should have concerned about the result of this treatment. And in following session, after about 1.5 years, we had no recurrent caries, chipping, or fracture. And however, the long-term follow-up is needed for this case. Okay, thank you for your time and attention. And here you can see my email address and also my ID on Instagram. And if you want to contact me, you can use these tools. And finally, I want to show you a short video clip about Iran. Actually, I know that in these days, you have seen many beautiful video clips, but this has been made by my sister, and many of these photos has been taken by herself. Actually, she had prepared it for a contest in her university in Canada, and the topic of that contest was introducing your country and the different monuments, beautiful sightseeing that Iran has, and also about the arts and handicrafts that we have in Iran, and also delicious food and sweets. Hope to enjoy it, stay safe, and have a good time.
Thank you, Dr. Valizadeh, for your nice presentations. It was very useful. Thank you for that. And now we are waiting to see your clips about the Persian land that your sister kindly provided. Appreciate it.
Thank you. Bye.
Welcome back again, guys, and I hope you have enjoyed the beautiful pictures and images of the Persian land that Dr. Valizadeh kindly provided and presented to us. I would like to know if anybody has any questions about the presentation of Dr. Valizadeh. Please, you can write it in the chat box if you like. Or at the end of the session, you can ask your question. Is there any question that I can help you? Okay, apparently, pardon? Apparently, I cannot see any question in the chat box. Now you will have a demonstration video which illustrates how we can restore a tooth endodontically treated with wallpapering technique. It will be a video and you will see how it can be done. At the end of the video, and then we have a question and answer session. If you have any question about this technique, you can ask your question, write in the chat box, or raise your hand and I will answer the question. If any time remains, several cases will be presented and we will talk about the different approach of restorative treatment planning, and you can ask about the treatment planning. So now we have the demonstration video. I hope you enjoy it. Okay, after demonstration video, we will come back and see you again. Thank you. Hello everybody, and welcome to the second part of the virtual program of Winter School at Restorative Dentistry Department. I'm happy to have you here. It's 2020 and 2021, and pandemic conditions suffers us a lot, and I welcome you all to the virtual session again. As you know, dental enamel junction is highly important to distribute the stress in tooth structure and transfer stress between enamel and dentin. But what we can do in a tooth is highly compromised, that the tooth structure has been severely compromised due to severe caries or previous endodontic treatment or very severe caries development. So we do not have enough tooth structure and remaining dentin enamel junctions to distribute the stress between enamel and dentin. So how you restore the tooth by this way? Different options of treatment are available, such as cast restorations or porcelain fused metal restoration, especially for those teeth that received endodontic treatment or amalgam buildup. But whether this restoration bond to tooth structure? Of course not. So one of the most conservative procedure of restoration of this highly compromised tooth structure would be using composite resin. Composite resin by itself, per se, has enough stiffness but lacks toughness to prevent the propagations of crack. But as I told you before, in the first of my lecture, you understood that dental junction prevents the crack propagation. I want to use something to be helpful to prevent the distribution of the crack in the total bulk of the restoration. And what can I do? What can I use? It has been proposed in different literature that fibers can be highly helpful in preventing the crack formations in the bulk of the composite restorations. In these sessions, I want to show you a tooth that has been severely compromised, previously received endodontic treatment, and will be restored with a composite restoration using fibers applied on the wall of the tooth structure and the restoration as well to reinforce the tooth structure. And those fibers act like dentin enamel junctions to prevent crack formations in the tooth structure and also in the bulk of the restorations. And this restoration, that is called wallpapering technique, has been presented and was introduced by Professor Deliperi, Simone Deliperi, and I will download his paper in the virtual educational program called Mwp System. Later you can have an access on it and completely read it and all the details. It's a 6-step procedure. I show you in these sessions step one by one to be familiar with this procedure. Thank you. We'll start the restoration. Okay guys, you can see a tooth that has received endodontic treatment is a lower first molar. We can see that tooth structure has been severely distorted. We do not have a distal marginal ridge and lingual wall here. Just as you see, the buccal wall has remains and the mesial marginal ridge. You can see the thickness of the wall is around 2 millimeter, and it has been explained at the papers and the literature explained by Professor Deliperi that 2 millimeter thickness of the wall might be enough to keep the tooth structure, and using that tooth structure for supporting the restorative material during the buildup of the restoration resin composite. Because the tooth structure has been severely destroyed, so lower amount of dental enamel junction has been remained, as I explained to you. I want to reinforce the remaining tooth structure, and we add additional composite to restore the bulk of the tooth. So you see, as I told you, we have here the buccal wall and the mesial marginal ridge. Now I want to restore the tooth with resin composite restoration with the wallpapering technique. I prepared the matrix band. You can see here. I want to fix it around the tooth. As I told you, it is the wallpapering technique, 6-step procedure. The first step, I forget I explained to you, I'm so sorry, is the occlusal analysis of where is the occlusal force that applied over the tooth structure. And then we go further to the next step to restore the tooth structure. And that is the removing the remaining carious dentin or enamel very conservatively, in order that to as much as possible the tooth structure is preserved. At the third step, once we start restoring the tooth, I have prepared the matrix and matrix band at the holder. I want to fix it around the tooth. You can see here, I fixed it around the tooth. It is highly preferred that if gutta percha has remained in the orifice of the cannula has been removed, but because of the saving of the time, I do not do it now. So I fixed the matrix band around the tooth structure. You can see it. And now we start procedure of the etching and bonding. As you know, it very better than me, much better than me. Now I applied the etchant around the tooth about 15 seconds. First on enamel margins. First I applied it over the enamel margin, as you can see here. And then it's applied over the dentin. So totally we have around 15 seconds for etching of the tooth structure. Then we rinse the tooth to remove the etchant material. To completely rinsing to remove any etchant gel. Now we want to remove the bulk of the water. I use the air spray, but we try to avoid drying tooth structure. So it wants to dry the tooth. I use the cotton pad to keep the moisture of the tooth. You can see here, I use the cotton pad. I can use another one. So the moisture of the tooth is preserved. Now is the time of application of the bonding agents. The bonding agents that is used here is the Warden Step Etch and Rinse adhesive system. As you see here, the single bond. But according to Professor Deli Perry papers, the fourth generation of bonding agent has been recommended that use primer and bonding separately, but it is a one-step etch and rinse adhesive system. I applied over the tooth structure, as you can see, completely to saturate the tooth structure with the adhesive restoration, with the adhesive resin. So 2 layers applied. I completely wet the dentin and enamel margins with adhesive completely. Then we use the air syringe to evaporate the ethanol, the carrier of the bonding resin, and tightening it. And after that, we cured the bonding agent totally in about 20 seconds. Here we used the LED light curing unit. Because the tooth structure, the molar is about 8 millimeter in width, but the tip of light carrying unit is about 4 millimeters. So we try to overlap the tooth structure in order that all the area of the tooth that bonding agent has been. Now I applied the light cure the mesial wall, mesial portion of the tooth. As I told you, the tip of the diameter of the light carrying unit about 4 millimeter. But I wanted to cover the all tooth surface in order that the light carrying resins is cured completely. And so, the first step after applying the binding agent is reconstructing the lost wall. Here is the lingual wall and distal marginal ridge with the enamel composite. No, I have unfortunately just one color of resin composite, A1. So, but if you want to restore the tooth structure, it is preferred to use two types of composite with opacity, enamel, and dentin. So the first layer, in order to restructure the lost wall of the tooth, would be enamel, around 1 millimeter thickness. So I applied first on the lingual wall that has been lost. I adopted completely on the margins and applied incrementally. As you know, it is not a bulk fill restorative composite material. So I should be careful to not apply composite resin more than 2 millimeter thickness. So the first layer around 1.5 millimeter applied on the lingual wall. I cure it about 20 seconds. Now I applied the second layer, about 2 millimeter thickness or 1.5 millimeter thickness. On the lingual wall again. Adopt it on the wall and the matrix to make the lingual wall. You can see here the lingual wall has been gradually formed. I cure it again. At a curing lingual wall, the distal wall is formed by resin composite with the same procedure that I explained to you, with the incremental layer, in order that to the depths of the composite resin, the light is penetrated and the composite resin is cured. Okay, you can see here that the lingual wall and the distal marginal ridge that has been lost previously has been restored with about 1 millimeter thickness of resin composite that should be in enamel. Now the wallpapering technique is started. As I told you, the fibers is used here acts as dentin enamel junctions to distribute the stress is applied over the tooth. For applying the fibers that has been recommended here is woven or braided in order that they distribute the stress in different directions, because the fibers has different directions. We applied a little amount of the flow composite on the wall, and then we adjust the fibers over the flowable resin composite that very amount of little that has been applied over the tooth. Can you see? So the width of the fibers is around, the occlusal gingivally is around 4 millimeter. And the dimension of the lingual wall is about 8 millimeters. So the fiber has been cut previously with the mesiodistal extension of the wall is 8 millimeter, and the occlusal gingival width around 4 millimeter, about the dimension of the dental enamel junctions of lingual wall. You can see clearly here. One who knows that you should very be careful about is that when you apply the fibers, it should be applied of about 1.5 millimeter gingival to occlusal margin, that when later you adjust the occlusion, the fibers does not expose to the oral environment to avoid degradations of the fibers. So you can see the fibers has been adjusted very clearly on the lingual wall by using the little amount of the flowable resin composite in order to reduce the amount of shrinkage stress following the polymerization. No, I polymerize it. So as I told you here, fibers acts as dental enamel junctions to distribute the stress when the occlusal force is applied over the tooth. We should do the same procedure for the distal wall. Be careful that the fibers turn around the tooth. So the fibers over the lingual wall overlap the fibers on the distal wall. Now, I place the second part of the fibers after apply the little amount of the fibers, a flowable resin composite over the distal wall. I think you can see the little amount of flowable composite, and then I adjust again the fibers over it, over the flowable resin composite. It will be extended, turn around. The fiber should be turned around the wall, including the vocal wall as well. So adjust it over the wall and has been extended, turn around the tooth like C shape. So the fibers take around the walls, including the buccal wall and distal wall, and a little bit over the lingual wall that has been previously restored. So join the tooth structure together. Can you see it clearly? I hope so. And now, again, we cure it. Just one wall has been remained, the mesial wall. Do you remember? So we applied the fibers over the lingual wall. Then on the distal wall that we have restored it with the resin composite, it turned around the tooth. On the buccal wall and restructured lingual wall. So be careful, the fibers overlap each line angles in order to join different parts of the tooth together. No one wall has remained. Apply the little bit flowable composite on the mesial wall. I try to reduce the amount of flowable composite as much as possible to reduce the amount of shrinkage stress that cause following the curing. I hope you can see it properly. Now I cure it again. So we join different portion of tooth structure together with the fibers, and the fibers acts, as I told you, as dental junction to distribute the stress. And when you apply the fibers over the remaining walls, that here is buccal and mesial marginal ridge, what does it do? Here the fibers reduce the bulk of the final restorative material, so the overall polymerized shrinkage will be reduced. But when you use the fibers over the lingual and distal wall here, it acts like dental junction. So the performance of the fibers is different in these two portions. And one portion acts like the dental junction, and other portion it will be helpful to reduce the total bulk of the resin composite material. Professor Deliperi has recommended we can apply also fibers over the floor of the pulpal chamber. We can do it as well. If you like it, you can do it as well. But we try to avoid it in order to save the time. No, we should apply resin composite layer by layer in triangular shape in order to avoid bonding avoid more than two surfaces together to reduce the C factors. Now I apply resin composite in a triangular shape, just two walls together, not more than that. First on the pulpal chamber and the floor of the pulpal chamber with a thickness not more than 2 millimeter. As you see it and apply it, it is just applied over the buccal wall, lingual wall that has previously formed, and the floor of the pulpal chamber. So just two walls to avoid lots amount of shrinkage stress that might cause these two walls separated because of the stress that is formed. Now I cure it again. The triangular shape of composite resin that is applied. Be here because the depth is about more than 4 millimeter. I should use higher power of the light curing unit or increasing the time of the light curing. So instead of 20 seconds, I increase the time of curing for about 40 seconds. After finishing applying the composite on the resin wall, on the lingual wall, I applied now on the buccal wall and floor of the pulpal chamber. Now it is applied the buccal wall, as you see here, completely adapted to the wall. You can use the micro brush as well, and the floor of the pulpal chamber. And cure it now. According to recent literature, you can use the bulk filled resin composite as well, but I do not use it here. We didn't use it here. And then go to the other layers. Here's apply the 2 millimeter thickness of the resin composite over the distal wall, just distal wall again, and the pulpal chamber in triangular shape. The pulpal floor and the distal wall completely adapted over the wall. Now I cure it again. If your instrument is not a stainless attached to the resin composite, you can wet it with a little amount of the alcohol or unfilled resin bonding agent to avoid sticking of the resin composite over the instrument. As you saw, I applied composite resin layer by layer. And now I go to the next step to apply resin composite over the other layer. By this approach, the fibers are completely covered with resin composite. So after occlusal adjustment, even after occlusal adjustment, the fiber will not be exposed to oral environment to be degraded following the time. And again to the lingual wall. Completely adapted, and on the pulpal chamber, floor of the pulpal chamber. But when you come gradually, when the restoration is filled and we reach to the occlusal surface, we can form the occlusal surface and the cos in one layer, one single increment, but not now. About one layer has remained, or 2 layers has been remained until the occlusal wall and the cusp is formed in a single increment. So the next layer is applied over the vocal wall. And again, just 2 walls connect to each other. Again, vocal wall and the floor of the restorations. One thing I should remind you. As you know, we have 2 types of fibers. It might be previously resin impregnated or has not been pre-impregnated with resin, adhesive resins. The type of fiber that was used here has been previously impregnated with adhesive resins, so we didn't apply resins, adhesive resin over it and use it. But if you use those type of the fiber braided or fiber woven that has not been impregnated with adhesive resin previously, you should apply bonding agent over the fibers, remove the excess amount of the resin, adhesive resin, then you use it. But as I told you, the fibers that I used here has been previously impregnated with the adhesive resin, so I didn't apply adhesive resins over the fibers again because it was previously impregnated with the adhesive resin. No, I tried to form the occlusal wall with the single layer. Now I go to the lingual wall, the lingual cusp. I try to form the mesial and distal cusp. But we should not forget the forming, adjust the material over each layer to avoid entrapping air between the layers. So completely pack each layer to previous layer to avoid air entrapment between the layers. So the mesiolingual cusp has been formed here. And 2 millimeter thickness. And then I should form the distolingual cusp. So the mesiolingual cusp has been formed. Now I form the distolingual cusp, and at the same time form the marginal ridge as well. As I told you, I try to completely adapt each layer together to avoid entrapping of the air between the layers. Be careful about it. Be patient. It's very important because it's a static restorative dentistry. So it is highly important to be patient with patience and apply all the arts you have over the craft you made. So this is the distolingual cusp and the distal margins. I formed it. So you see here that the remaining walls, it was a buccal cusp, and the distal marginal ridge has been formed with using the resin composite incremental, layer by layer. But as I told you, the occlusal cusp was formed with a single increment of the resin composite. After forming the total form of the tooth structure layer by resin composite in addition to the fiber we use, the finishing of the restoration is started. You can use bears, diamond bears, finishing diamond bears, or aluminum disc like here to form it. If you have access on the tooth surface in order to avoid the adjacent soft or hard tooth structure, you can use it. For example, here. You can remove the excessive amount of the material using the finishing depth. And so after finishing the restoration with different types of the finishing instrument like disc, aluminum disc or finishing bars, you can see here you can apply the unfilled resin unfilled adhesive resins in order on the tooth surface in order to fill the cracks that improve the longevity of the tooth restoration and provide the color stability of the restorations of the resin restorations. As you see here, I applied the unfilled adhesive resins over the composite resins. Before application of the final step, that is application of the unfilled adhesive resin, you should adjust the occlusion in order that the occlusal force is applied over the axial axis of the tooth structures, and it is preferred that the contact is on the resin composite, or if the tooth remaining residual wall and the resin composite, the intensity of the load should be equal. So the intensity of the color using by articulating paper the intensity of color of the articulating paper over the tooth on the resin composite and the residual wall of the tooth structure should be the same, not higher than the other ones. And it is preferred, according to Professor Deliprey literature, the occlusal contact is formed on the restorations, on the resin composite restoration, in the axial axis of the tooth to prevent the application of the excessive lateral forces over the tooth that might reduce the longevity of the tooth restorations over the times. So I hope that this explanations and this demonstration was helpful to you, that when you face with a tooth that has been severely compromised, one of the economic options to restore the tooth would be reconstructing of the remaining tooth structure using resin composite and wallpapering technique according to Professor Deliprey recommendations. As I told you, is one of the economic options, but other options is also available for the tooth restoration for conservative approach of the reconstruction of tooth structure, like ceramic onlay or endocrowns or overlay. We're using cast, different type of cast like gold or base metals. But this approach is beautiful with a natural tooth color and economic as well. So it would be one of the options that you can choose in your dental practice. Best wishes for you. Thank you for patience and best wishes in the new year 2021, free of any type of disease and COVID-19. I wish you safety, health, and happiness over the time, now and for always. Bye-bye. Okay, guys, welcome back to me. I hope you have enjoyed the presentation of Dr. Valizadeh and the video. They have seen how this endodontically treated teeth with 4 remaining wall can be restored with wallpapering technique according to Professor Deliprey recommendation. All these details has been achieved by the techniques presented by Professor Deliprey. You can use the full text of these papers in the Navi system. Uploaded in about, I think it was on Friday, 12th of February. You can go and see Navi system, download it and read it in details, line by line, to know how you can do it. So review the method again in order to use it in a practice and for patients. Okay, I can see that are several questions here. I will answer this question one by one. Okay. Farida, so I start from the first question. Farida have a question. Why don't you start with flowable dentin? Farida, would you please unmute your microphone? Then we can talk about this question more, because I do not know exactly what is your questions. Farida, I'm waiting to unmute yourself. Would you turn on your video as well to have a vital communication with each other? all of this communication was virtual. I could not have a good sense, like a virtual condition. Would you please turn on your video and unmute yourself to ask your question in more details? Because it is a wide question. I do not know which point of view do you consider on.
Hello, I'm sorry, I can't open my video right now. My question was about when you started to put composite. I saw you put the part of composite material. That was my question. Why didn't you start with putting flowable dentin, then putting normal composite material?
Okay, So you may, I think your question is about the snowplow technique, that in order to improve the adaptation of resin composite to the tooth structure and tooth margins, a very small amount of fluidable composite is applied first, then the hybrid composite applied over it and gently packed in order to improve the adaptations. Is it your question?
Yes, yes, exactly.
Okay, we can use it as well. You can use it as well. But because I just want to follow all the details has been presented in the technique of the Professor Deliperi, I didn't use it. But as you mentioned, thank you for your recommendation. One of the techniques to improve the marginal adaptation is using the snowplow technique. The first, we apply a very small amount of flowable resin composite first. Apparently the connection has been disconnected. Do you hear me?
Yes, 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 I hear.
Yes, a small amount of flowable resin composite is applied first, as you mentioned, then the hybrid composite apply over it. You can do it as well, but I didn't say that because it has not been written in the papers. And again, for this technique, for snowplow technique, as you know much better than me, it is highly recommended we use more highly filled flowable resin composite for this snowplow technique, because as you know, the flowable resin composite has less resin, more resin and less filler. So the polymerization shrinkage, this type of composite is more. So we prefer to use the highly filled flowable resin composite in the snowplow technique. Is it clear?
Yes, yes, thank you so
Do you
much.
have any other question about this, Phil?
I had there in chat box a second question too. If it's okay, I can ask now, right now.
Yeah, you can, please.
I
Feel
asked
free.
about fibers. I have never seen using of fibers in bonding. So I want to ask, what is the exact function of them? Yani with or without, what we gain and what we lose?
Your question is about this technique or about the fibers totally?
In this technique, you say
In this
use of
tech-
fibers.
Yes. As if you, I recommend you, if the video is available, to review my video again. It's the Mwp system. If it is not available, please go and read that the papers in details in order to hack it in mind. But I explain to you. The wallpapering technique, the fibers that has been used simulate the dentino-enamel junction. So the wallpapering technique recommended by Professor Deliperi is for simulating the last dentino-enamel junction in order to prevent the crack propagations, if any crack is formed in the restorative material. Is it clear? Or no, I could not answer your question.
Clear. Thank you for your response.
Okay, so for this technique, the fibers has been used to simulate the dentino-enamel junction. And because of that, during the video film, if you have heard that, the width of the fibers should be in occlusogingival dimension in the height of the crowns. So if the height of crowns about for molar about 4 millimeters, 5 millimeters, if you consider that it below the enamel until the cement enamel junction is about 4 millimeter height of the dentin, coronal dentin. So the height of the fibers occlusogingivally that you place in each wall, baccally, palatally, mesially, or distally, should have a width about 4 millimeter wide. Or if you do it, this technique for premolar teeth, you should use the width of the fibers for the same tooth. Is it clear?
Yes, thank you so much.
Okay, thank you. Thank you for considering the video and you have enjoyed the film. I appreciate it. And the other questions by Moritz, if I spell it properly. The next question is it effort worth it? Is it better to apply to, oh, I'm sorry, I made a mistake. The next question was from Behnaz. Behnaz, would you please also turn on your video or unmute yourself? We can talk together about your questions like Farida. It gives a better feel and better sense in a vital conditions. Hello, Behnaz. Nice to meet you.
Hello, how are you?
Good morning. Good morning. Thank you to turn on your video. You are the first for this
You're
session.
welcome.
Another video. Thank you. I appreciate it. Okay. I read your question again, and I will try to answer your question. Is not better to apply 2 layers bonding? Thank you for questions. As you mentioned here, if we use etch and rinse adhesive system according to manufacturer structure that you have here, we use adverse single bond. You are true, you are correct. We should use 2 layers of bonding agent. The first layer is applied over the dentin, of course, not dry dentin, on the blood dry dentin, and apply a thin layer. Then we use the air spray to evaporate the any carrier ethanols or any carrier in the bonding agent. Then we apply the second layer, and after that, again we use air spray to evaporate the alcohol or any carrier in it. Could I answer your question?
Yes, yes.
Thank you.
And another question is that if you apply 2 layer of bonding, is it if you apply 3 layer in any kind of restorations, is it necessary to cure the first layer, or is it better to not curing the first one?
No, according to manufacturer, you should always follow the manufacturer instruction. I cannot say I cannot give a total recommendations, but usually those bonding agent that according to manufacturer instruction that usually is related to etch and rinse adhesive system, 2 layers are applied and then cured after the evaporating the solvents. Of course, another important issue that I should mention here, and I wish that all guys follow it, is we try to make the adhesive layer as thin as possible. So when we apply the adhesive agent and you use the air spray to evaporate the solvent, the aim of the air spray is to evaporate solvent, not making thin. For making the adhesive layer thin, you should use a dry brush, micro brush, in order to absorb the excessive adhesive layer to make it as much as possible thin, because it is the weak point. The thick adhesive layer is at the weak point for the future fracture or failure.
Yes.
Was it clear, or if you have any other questions that
yes,
I can help
clear,
you?
Totally clear. Thank you so much.
And thank you for the turning on your video. I can have a sense of vitality here. Thank you. I appreciate it. Have a nice day. Please be with us. Please be with us in the remaining time. Thank you. Thank you.
Thank you so much.
Welcome. Welcome. We will go to the next question. Moritz, I don't know. I spell it properly or not. Moritz, hello. Good morning. Nice to meet you. And hello. Thank you for joining us. Hello.
You say in German Moritz, but Moritz is completely fine.
Moritz. Okay. Thank you for accepting my spelling. I'm sorry. I missed your picture for seconds. And thank you for joining the winter school and also joining for the Restorative Dentistry Department program. I read your questions to know whether I understood your question properly or not. Is the effort worth it? One day this tooth needs a partial crown or full crown for stability. Or do you mean with this wallpaper technique, the tooth needs no crown? Moritz, again, like Behnaz, I recommend you to read the paper of Professor Deliperi as well. For each type of treatment planning, we should have an appropriate selection of the tools for that treatment planning. So for the wallpapering technique, the remaining wall thickness for this technique should be at least 2 millimeter or 1.1 millimeter. It means that the remaining tooth structure has enough dentin support. The tooth remaining structure are not fragile. So if we use this technique, this treatment planning, this type of treatment could give a long service for the patients. By this way, you delay all aggressive treatment planning. So instead of placing a crown for these tooth for a patient for about 25 years old, you delay this aggressive treatment planning when he or she is 50 years old. So you cannot guarantee any type of restoration for a long period of time. But by this conservative approach of treatment, you delay all aggressive treatment planning. Is it clear?
Yes, very clear. So it's worth it.
But your question was very gently, and you consider to details that about the crown. Yeah, your last question, your last sentence was a crown. If we have a tooth with 2 millimeter wall thickness, if we started with wallpapering technique, it can give a service, oral service for several years, for example, 5 years, 6 years, 10 years. If any failure occurs, 1 or 2 teeth remains. So the next treatment planning, what would be? Overlay. Again, the tooth structure remains. We never go to the crown. We try to avoid the crown as much as possible, because if we do crown for this tooth that has 2 millimeter thickness wall, we will lose the all remaining tooth structure. To try to avoid any type of treatment that ends to the crown. Crown means killing the tooth. I want to avoid killing the tooth.
First, I said partial.
I don't know. I could answer your question, or you need more explanation.
Yes, you answered it really well. Thank you.
Thank you. Thank you for participating and joining us.
The pleasure is mine.
Have a nice time. Thank you. Bye-bye. But we're waiting with our program until the end, because we have a good break as well.
Yeah, of course.
Thank you. I appreciate it. Thank you. Okay, we go to the next questions asked by Noor. I don't know, I can spell it properly. Noor, would you please, like other guys, turn on your video and unmute yourself? Hi, hello, thank you.
Hi, what are you doing?
Hello, good morning. Is it morning?
Good morning, teacher.
Your country? I do not know which country are you?
Yeah, now it's like 9 a.m. at the morning.
9 a.m. So similar to us. Good morning. So I should say good morning, not good night or good evening.
Good morning
welcome.
to you, and thank you for inviting us.
Thank you that you're accepting and joining to our program. So I read your questions to know whether I can help you or not. Your question has been written, but the tooth has root treated. There is no pulp. Yes. What is your question? Would you please more clearly ask a question? Because this technique is for endodontically treated tooth.
You are right. This is there is made root canal treatment. Is it true?
Yes. Yes.
You say that the purpose of this technique to stimulate the dental enamel junction.
Yes.
But there is no pulp. This tooth is dying, so we are only putting something to constructive the tooth only for the shape. How we can stimulate the dental enamel junction if the tooth are dying?
Dental enamel junction there is no relation between dental enamel junction or the vitality of the tooth. In the tooth structure, we have whether it is vital or non-vital and have received endodontic treatment. We have enamel layer, that's external layer. Then we have dentin enamel junction that join the enamel layer, the external layer of the tooth to dentin, that is internal layer. So whether the tooth is vital or whether the tooth has received endodontic treatment, we have tooth structure. So we have enamel, dentin enamel junction, and dentin. And inside in the core of the tissue, in the core of the dental structure, we have pulpal tissue. So according to this technique and Professor Deliperi, this technique has been used for endodontically treated teeth, but can use it in the vital tooth as well. If I were you, if I have a severely destructed tooth that is a huge amount of dental structure has been lost because of the caries lesion, and the remaining wall about 2 millimeter thickness or 1.5, I might use fibers in order to reinforce the material as well the tooth structure. both of them, because the fiber reinforces the material as well, prevents the crack propagations, so improve the fracture strength of material. In other signs, the fibers that has been used here has simulated the dentinal enamel junctions in order to prevent crack propagation, any crack propagation. So improve again the fracture strength of the total bulk of the tooth that has been restored. Was that okay? Ask the question again.
Yes, and the second question I have.
Please.
As we saw, the tooth layers, the original tooth layers is so thin. There is, and exactly from the dental-enamel junction, the layers. If the patient will eat some hard substances like apples in the future and without a bulb, so there is no any generation of the enamel and dentin in the future, maybe it will have fracture. Why we can't? What's your opinion to put some supportive things inside the tooth and then build on this supportive materials by composite? Like if we can't put it vertically, we can put it horizontally, like a cross.
You mean like overlay or onlay? Do you mean that? Okay. Did you read the papers that I have downloaded uploaded in the Navid system? Exactly, no. The questions could be answered in those papers. Noor, I don't know what your name was.
Yeah, my name is Noor.
Noor, Noor. In this video, the wall was not so thin. As I explained, the thickness about 2 millimeters. 2 millimeters means about 1 millimeter thickness of enamel, about 1 or 0.5 dentin. So that the remaining tooth wall should not be thin for this technique. Otherwise, you should not use it. If the thickness of the wall is not enough, about 2 millimeter, as you mentioned, you should reduce the cusp height and you use the cusp coverage restoration, especially on those tooths that have lost the marginal ridge. For example, if you have a tooth that has received endodontic treatment and have an MOD cavity in addition to access cavity for endodontic treatment, and you have just buccal and lingual wall, definitely you should follow the cusp coverage restoration that is called overlay or onlay. And the material could be ceramic or the lab-made composite resin.
Can we put this supportive horizontally, not vertically, if we have root problems?
Support with what? Support with fibers? Do you mean using fibers?
Yeah, like some panel, like fibers.
Fibers for this technique can be applied in several directions. One of the directions are placed wrap around the tooth on all the walls. Is it fine? Another area that the fibers could be placed and has been recommended in these papers as well is to place it in the pulpal floor. Okay? In order to improve the strength of the remaining tooth structure. If you want to use fibers to reinforce the material, there are some composite that reinforce inherently by fibers itself. So instead of fillers, or in addition to fillers, silica fillers, fibers has been included in the resin composite as well. So you can use in this technique the composite material, composite restorative material that has been reinforced with fibers in itself. So in this technique, you use fibers wrap around the walls. You can place it horizontally in the pulpal floor as well. Also, and not in this technique has been mentioned, in the clinical practice in restorative dentistry department, you can use the fibers in different direction. You can use it, there is no problem, but you should try to avoid any void and bulb between the composite and the fibers. Otherwise, the voids that will be created with the fibers and the composite will be the point of the start of the crack propagation.
So if I will come to you and you will do to my tooth this technique, yes. And I will ask you, how many days, how many times, like 1 year, 2 years, 3 years, I can preserve my tooth?
And nothing has been written in these papers about how long would be the service of this material, of this type of restorations. But if you use it properly, like any type of the restorations, the composite resin can at least remain for 5 years. So the 5 years, the minimum time that the technique is recommended for a restoration of a tooth. So the 5 years is the minimum time.
Thank you so much.
It could be much longer. The 5 years would be like a minimum time, but more time would be possible, definitely.
If there is more time at the end of this, I have one question. Yesterday, we had with Dr. Nikofar, he's endodontics professional, and I forgot to ask him this question. I asked it here to a lot of teachers, and each one answered me different answers. My question is, if we are doing root treatment by file, using file, and this file will broke near the apex of the roots, is broke.
Mm-hmm.
At that time, what's the technique to remove this piece of file from the end?
No, I'm not endodontist, so I cannot answer your question. Did you ask this question yesterday?
No, I forgot.
I will ask the endodontic department that how they can communicate with you. I write your name here, Noor Mizdam, that how they can contact you to answer your question, because one of the aim of the winter school is that the student completely understand of what all issues that has been explained in this short course. So I wrote your name. I will ask endodontic treatment to contact with you, answer your question, because I'm not endodontist, so I cannot explain how the broken file can be removed from the canal. I'm so sorry.
Right.
I'm sorry.
No, it's okay. I asked
about your question about using fibers in different directions in these techniques that I mentioned, you should consider one point. Try to avoid excessive amount of fibers in your restorations, because many amounts of void is created in the bulk of restorations. So we need to use adequate amount of fibers in necessary area, as in this technique has been applied over the wrap around the balls. Another area that has been placed in this technique has been placed horizontally over the pulpal floor. You may use 1 or 2 fibers placed vertically if you like, but try to avoid excessive amount of fibers, because in the other side, it will be a weak point in your tooth restorations.
I got it. Thank you so much. Really, I appreciate a little of your knowledge that gave to us, and also your kind face and kind voice. Thank you so much.
It's all kind of you. Please do not hesitate to contact with us after finishing the summer school. Still, we have a communication with each other. And I hope you and other guys enjoy this program to motivate them enough to participate in the postgraduate program in order to learn more knowledge, more skill in the how to restore the tooth on the lost tooth in more conservative manner. We can learn a student in the best method with the high knowledge, the best method of restoration of lost tooth extraction and conservative, ultra conservative, and also learn them how to create a very beautiful smile line with ultra conservative approach as well. That is one of the great demands nowadays in the population around the world.
Wonderful, wonderful, and so interesting. I hope it's so.
I hope to meet you soon in TUMS, a dental faculty and restorative
department.
My
proud and my comfortable.
Thank you. It's an honor as well. Best wishes for you. Have a nice day. Please stay with us. Bye-bye. Bye-bye. Okay. There is another questions asked by Morris. I asked you a question previously again. Oh, no, I'm sorry. Another question is by Amir Hossein Raji. Welcome, Amir Hossein. Would you please turn on your video? Like your guys and your friends? Can you unmute yourself? Great, it's wonderful. I'm waiting to see your face. Please unmute yourself as well. Would you please turn on your video or unmute yourself? Okay, probably you do not like to do it. Yes, you should allow me. Okay, we من ببینم سوالشون ببینم. Okay, I mean, probably there is some technical issue where they cannot have a video of you, of Amir, but you can unmute yourself if you want to talk. We may not have your video, but you can unmute yourself. We can talk together. I read your questions. If you have any, I try to answer your question. If you have further question, please, because you are on mute, you can ask your question. Your question is that the case selection criteria exactly for this technique seems to be similar to endocrown. No, I will explain to you. And please, again, I ask you and all guys to read 2 papers that have been downloaded in Navis system. That what is the indications of endocrown? Exactly, the selection criteria has been clearly explained. Please don't forget it and refer to these articles. But here also I will explain to you. The case selection criteria for this technique seems to be similar to endocrown, as both techniques are pretty conservative. Yes, it is the common point between these 2 techniques. Has there been any comparison about the longevity of these 2 techniques? So this question has 3 parts. I try to answer your question part by part. The first part is that the selection criteria is similar to endocrown. Amir, in this wallpapering technique, you saw that the remaining tooth structure has 4 remaining walls with 2 millimeter thickness. Is it right? If you forget it, please refer to the papers that have been downloaded in Navis system that I repeated several times. So in this technique, we have 4 remaining walls: mesial, distal, buccal, and lingual or palatal, with 2 millimeter thickness. But for endocrowns, we have endodontically treated tooths that 2 marginal ridges, mesial or distal, has been lost, or even buccal and lingual wall are so thin. Then we need to reduce the height of the buccal and lingual wall about 2 or 3 millimeters to provide thickness for later ceramic material or later composite restoration, lab-made composite restorations, in order to provide endocrown. So the selection criteria for these 2 techniques are completely different. For the wallpapering techniques, I have 4 remaining walls for about 2 millimeter thickness. For endocrowns, I have lost 2 marginal ridge, so I do not have 2 walls, 2 fundamental walls, in order to improve the fracture strength of the tooth, because if I lose marginal ridges, the strength of the tooth severely reduced, and there is a high probability of tooth fracture. Then we need to follow the cuspal coverage restoration, that one of them would be only over the endocrowns, in order to cap the cusp and distribute the forces to prevent the excessive fractures of buccolingual wall suddenly, that the tooth might not have any choice to remain. So we're using endocrowns. We try to avoid this and avoid what can I say? The tooth that cannot be treated anymore. The tooth might be lost. If it's the remaining wall buccolingually fractured obliquely extended under the crest, and we cannot do anything else for that. I hope I have answered your question. Can you unmute yourself that if I could not answer your question, explain to you more? Or you can write in the chat box if you cannot unmute yourself. I cannot see, is it my connection? Guys, one of the guys has been written that I cannot see. Dr. Mutawassilian, is it my question? Okay, probably the connection is stable. We have connection together. I wish that Amir could unmute himself in order that could, I don't know, I'm be sure to, I was able to answer your question or not. So because I cannot, I will go to the next part of the question. Has been any comparison about the longevity of these two techniques? As much as I know, as much as I read the articles, I cannot say yes or no. I can say as much as I read the articles, I have not found any articles that have compared the longevity, clinical longevity, the duration of this structure remaining. In the one category that is wallpapering technique, 4 walls has remains. Do you hear me? And in the onlay or overlay on the crown, this is another category. So they are not compared together because we compare those groups that are can be compared together. So I don't think so. You can find any articles about this issue that these two restoration, that both of them are conservative approach of restoration of endodontically treated teeth, you can find it. But if you find anything, please let us know. I hope I could answer your question. Even you can at least write in the chat box that whether I could answer your question or not. Okay, probably I don't know. I could answer or cannot answer because Amir has not written anything in the chat box. So I go to the next question. Moritz, what are root amputations? Root amputations is for sectioning of the end of the root end. This treatment approaches to ask about is related to the endodontic treatment. So if you have any question about this, hi again.
That was an answer for Noor's question when a file broke at the apex.
Oh, I should say hello to you first again. Hello to you. Good morning.
Hello.
Hello. Is it morning for you?
Yes, very
Okay.
early.
early good morning. So very early good morning to you. And your question, Maurice, is about root amputation. Root amputations is
No, that is no question. That is an answer to Noor's question when a file broke at the apex.
If a fiber broke at the apex?
That is no question. Noor asked before when a file broke at the apex of a tooth.
It is answered the question of Maurice. Yes. Okay, I got it. I got it. Okay, thank you.
So we learned that is difficult to get this file out of the root. So there's mostly one way to hold the tooth, and that's a root amputation. But maybe the endodontic experts have another opinion.
Okay, of course, this treatment that you recommended for any files that has been broken in the tooth is the last approach. So endodontists try to remove the broken file as much as possible with different techniques that they have. If they are not successful, then they may choose a root amputation, because this treatment has several disadvantages, because the remaining lengths of the root will be shortened. So the longevity of the tooth in the oral mouth might be reduced. So you cannot always choose this treatment approach for those teeth that the file has been broken in the canal. So it depends on the tooth condition, the length of the root. Is it clear? Do you hear me?
Yes, it's clear.
Okay. So it depends on the length of the root and the root condition. This treatment approach is the last treatment approach if the endodontist cannot remove the files, the broken files, and retreat the canal again. So it is not good options, but if we cannot do any condition, but and according to selection criteria in the endodontic treatment, it might be one treatment approach, or it might not be done. So you do not think always to this way to relieve yourself from the broken file. It might be possible in some conditions. So you should try to think about another treatments to,
Yes, I'm
to
excited.
remove the file.
I'm excited for the solutions of your experts.
I tried that. I wrote your name as well. I will ask endodontic departments to contact with you and answer your questions. Contact with you. Waiting for the answer. Okay.
Okay, thank you.
Thank you for all your consideration. You're a very smart student. You will be a very good dentist in future. I'm sure about it. I hope to see you one day in Tehran, TUMS dental faculty.
You will.
I hope so. I hope so. Question that you want to ask me?
No, that's all. See you
Okay.
later.
Okay, see you later. Thank you.